Okay, welcome and thank you for joining us today at the Nottinghamshire Alliance Training Hub to discuss first contact occupational therapist roles in primary care. So today, if I can get my slides to work, there we go. Today, I'm going to do a bit of an introduction about what we're going to be doing. We have Jen Smythe from RCOT to explain the current national drivers for OT in primary care. We'll have some discussions about first contact OTs as physical OTs and then vocational OTs. And then we have a mental health OT working in primary care, Catherine Seal, who will explain her experience. And then I'll continue to talk about the NHS First Contact Practitioner Roadmap. So my name is Desi Gillespie. I am actually a MSK First Contact Physio Practitioner. I'm an OT clinical lead, as well as the R's Ambassador for Allied Health Professional roles at NATH. I'll hand over to Catherine. And if you don't mind, can you tell me how you got into first contact mental health OT?
Yes, so I'm Catherine Seals. I'm a first contact mental health OT and team lead for Nottingham West PCN. I first got into primary care through a secondment. I used to work in secondary mental health, and there was a lot of work, particularly during the COVID period, where scope opened up for us to be able to do some work in primary care. And so from that, it actually developed into a bit of a pilot. So I was working 1 day a week in primary care. And to be honest, the whole dynamic of it just really appealed to me. The getting to see people at the beginning of the journey rather than, at the end, really at the end point of their journey when they come through into the mental health team. I just felt like I was able to be a lot more proactive. There was a lot of diversions away from needing secondary services. I could catch things earlier. So it felt a lot more rewarding for me as a professional as well. So yeah, that was my driver really to start working full-time in primary care.
Thank you. And Jen, how did you get into working within primary care roles?
Well, I sort of feel as if I haven't actually ever practiced as a clinician in primary care. Obviously, I am an occupational therapist and I have a national role at RCOT, and primary care is one of our priorities. And I think my sort of passion for this area, so as I said, my role is in trying to promote and help get the OTs in primary care established and expanded, because we really need to expand the numbers. But my passion and drive for this area is very, very similar to what Catherine has just mentioned. My experience as a clinician was that very often by the time I saw people, they'd lost their homes, they'd lost their jobs, their relationships had broken down. And I used to think, if only I'd seen you at the front door of healthcare, which is primary care, if I'd seen you 3 years ago, this would have been a much more early intervention and prevention style of intervention, rather than the interventions I had to do that sort of felt like too little too late.
Brilliant. I look forward to hearing the rest. So if you don't mind just giving us a bit of an update of what's going on UK-wide.
Yeah, so just to help us understand then the national context for occupational therapy in primary care, in particular those drivers, which have been really crucial. Without these drivers, we wouldn't have any occupational therapy in primary care posts. So those first two are really important, that twinning of the policy focus, and related to that, the funding. So NHS England, the government in England, has really driven this vision that the future for primary care is a multidisciplinary one. And that's based on the idea that there's a greater range of people with a greater range of needs now turning up in GP surgeries. And we need a much wider range of different types of staff, different types of clinicians to be able to meet that need. So that future of primary care being a multidisciplinary one, and really being a biopsychosocial, personalised biopsychosocial approach. Because of that level of complexity of presentation, we obviously need a medical approach, but we need a much wider way of thinking, a wider set of skills. Twinned with that, luckily, the government have invested a significant amount of money and funding, particularly under the additional role reimbursement scheme in England. That's brought in a whole range of different types of new people who never used to work in primary care, and that would include occupational therapy. And we suspect that next year going to see much greater flexibility about how that funding for the expanding workforce in primary care can be used. So I think that's going to be really exciting for our profession. We're going to have an election next year, and what is going to keep this at the forefront of our politicians and civil servants' mind is the fact that it will be a priority. I'm predicting that at the NHS healthcare, and particular access to advice and treatment in primary care settings is really, if you've got any older adults in your family, they're talking about it right now, and that will help keep that focus because voters are worrying about it. There is an issue, not an issue, it's good news really, and that's the size of the occupational therapy workforce. There's about a head count of 43,000 occupational therapists in the UK. There's a head count of about 45,000 GPs. So we're a similar size workforce. So increasingly GPs are saying to me, not why should you be in primary care, but more why aren't you in primary care? Why are you hidden in a way in other parts of the system? And I think we're increasingly being welcomed into that front door of healthcare because there are enough of us, but we're just in the wrong parts of the system. And linked to that, I think there's going to be some really interesting workforce modelling that's going to be going on next year, looking at this issue about how do we best position the occupational therapy workforce and other AHPs in primary care, because there's lots of different ways of doing it, different employment models, different funding models. That's all going to link and be part of the RCOT workforce strategy that's going to be launched in 2024. Primary care is one of the priorities because we predict it's an area of growth, and we believe OTs will offer better value if we can get in early and offer much more earlier upstream prevention interventions. And as part of the preparation for that strategy and that priority, we've just refreshed our primary care webpage. We now have 9 different pages with loads of information in there all around occupational therapy and primary care. So I'd really encourage you to look at it. So shall we move on to the next slide then, please, if that's okay, Desi? So if you have a look at our webpage, one of the things we describe is the 3 biggest areas that occupational therapists have been looking at in primary care in the past couple of years is physical health, mental health and vocation. So I'm going to talk a little bit first of all about physical health and then about vocation, and then handing over to Catherine to talk about mental health. So predominantly this really is about older adults. So we did a survey about 1.5 years ago, and probably about 70% of the occupational therapists in primary care are offering predominantly physical health types of assessments and interventions, and that's mainly around frailty and older adults. In Nottingham, the focus has been predominantly on care homes. That is the same in other parts of the country, but actually there's a lot of wider work about occupational therapists supporting the needs of older adults and those complex sets of physical health problems. So we know by the time you're in your 80s and your 90s, people have got multiple comorbidities related to arthritis and their heart and cancer and poor eyesight. So they've got quite a complex set of needs, and occupational therapists are very comfy in that space. So some of those interventions have been about keeping people well in their homes, checking their mobility, their safety in the home place, checking they're able to manage their occupations, they can wash and dress themselves, they're managing their medication, offering carer support, trying to prevent hospital admission. And some of that work is a very similar type of assessment and intervention process that has been done in care homes. Interestingly, when we did our survey, and we asked for a little bit more detail about some of those physical health problems that they're working with. Cardiopulmonary came up, pain management came up, fibromyalgia came up in our survey, and also MSK and rheumatology. So as I said, in older adults, it's that complex set of needs that people will present with.
More
I think so.
More of a question that might come from, say, care navigators. If a patient called up, what is something they might say where you would put them with a first contact physical OT?
Usually, if they're calling the GP surgery, it's about a crisis of some kind. Often, if they're in their own home, so the care homes usually have quite a robust system and way of dealing with crisis. But quite often what we're finding is it's frail older adults who either live by themselves or there's an unpaid carer, a family carer working with them. And they've gone in and there's been some change in that person's presentation. They're acting differently. Hopefully they haven't had a fall, but they might be falling or they're starting to struggle. So I would say they're the key things that when that carer calls, if they start to, the thing that the first contact OT though obviously has got to do, as any first contact clinician does do, is understand and bring that knowledge around differential diagnosis, because obviously one of those things is frail older adults can present in crisis for lots of different types of reasons. There might and so our first contact OTs will have that ability to deal with that. Some of the earliest models actually used a paramedic and an occupational therapist working together to ensure that level of safety, to be able to deal well with differential diagnosis. What is the problem with this frail older adult? Is it a UTI? Is it something else? Is it the early signs of dementia? Is it a worsening of a physical health conditioning? What are the medical red flags that maybe need to be flagged and dealt with in other parts of the system? What's the home safety that has to be put in place now to keep the person functioning and well in their own home? So I hope that helps.
That probably links in nicely to kind of within Nottingham or within Nottinghamshire, this is kind of an example. This is not a hard and fast assessment, but just an example of kind of the things that a physical OT might do. So obviously if people call to the GP practice, then there might be some additional, given they'll be going into their home environment, whereas in this is when they're in the care home and already in a protected environment. So is there anything else you would add on? Have I missed anything about other things that you might assess?
No, I think the main thing is when OTs first started to work with older adults in primary care, there is a big focus on the acute emergency end of that patient's journey. So either it's helping them come out of hospital and get back settled in the home, because if that isn't managed well, people present with primary care in a big panic because they've been, chucked out of hospital and no one knows what's going on, and that turns up in primary care and someone has to deal with that. Or that early crisis. Does this person need to go into hospital or not? And we do great work in there. Loads of examples. There's a great several great case studies, action examples on the primary care web pages. But what I have noticed recently is with better use of frailty indexes, in some places they're using artificial intelligence to look at algorithms and screening for how can we actually get people, older adults, at an earlier stage of their frailty journey. So before you get into crisis, before you've even contacted us in the GP surgery, what's the outreach OT intervention? I think of it as like the OT vaccination we can give you to help you function well for as long as possible in your home environment, because that's what most people want. They don't want to go into hospital. They want to stay in their own homes and enjoy their own homes. So I think there's been a bit of a shift in the OT focus for older adults in primary care.
Thank you very much. And now if we can go to vocational OTs.
Absolutely. So vocational OT. So this has probably been one of the smallest areas of practice in terms of, remember I said there are three main areas: older adults, mental health and vocation. And we're seeing two different ways that OTs are offering vocational advice in primary care. It's either as part of their wider occupational therapy service. So for example, a mental health OT might offer vocational advice. However, we do have a few places in the country where they've set up vocational specific clinics, and that's been based on some research we did with the University of Nottingham. So these are two examples that have both just reported towards the end of this year. In London, in Hackney, they had some OT-led vocational clinics. Not the biggest reason for fit notes is respiratory problems. It's colds and coughs. It's a one-off fit note for 2 weeks. Not those people. We don't need to see those people, but particularly the people who are maybe coming back for repeat problems, or they're saying they need quite long periods of time off, and that it predominantly is around mental health problems, musculoskeletal problems. We do great work with that group because we offered much more detailed, tailored, specific advice. Most GP written fit notes, have no information on at all. They just sign people off. Whereas we're able to break down the health problem and the work situation in a greater degree of granularity and work out actually what is more specific, helpful, individualized, personalized advice that might help this person get back to work sooner. So we've seen some great reductions in that use of the fit note. It's less of a burden on the GPs because the people don't keep coming back and asking for repeat fit notes. And that was mirrored as well in the Yorkshire service. So very, very similar findings. And plodding away in the background, because the fit note changes happened last year, and that means now physiotherapists, occupational therapists, nurses and pharmacists can sign the fit note. We've been working with the DWP about updating the guidance and getting some more occupational therapy specific case studies in there. So I'd recommend them to you. There's one working with someone with long COVID and one working with someone with a musculoskeletal problem.
And as an OT clinician, how would you normally get into this area of OT? So obviously physical and mental have more of a, I would say, a normalized way of getting to the professions. What would normally you need to have done before to be able to work into this role?
This is covered as, so giving vocational advice is covered as part of the undergraduate curriculum. So from point of qualification, occupational therapists have the right skill, but obviously at the level of practice that they are, as with any clinician, you would expect a different parameters, a different amount of depth or complexity to that assessment and intervention process. So what we might get from a novice clinician offering a vocational assessment and an advanced practice clinician offering a vocational assessment will look and feel quite different. And we understand that as clinicians. But there's lots of other training out there, specifically around the fit note. There's a great fit note training module that people can do, and there's written guidance as well. And in the written guidance, it suggests ways that people can increase their skill level in this area if they feel that offering vocational advice has not been a lot of their past experience. So there are ways that you can expand your skills in this area.
Thank you. So now, if I can pass to Catherine to talk about mental health OTs.
Yes, so generally in primary care, mental health OTs are looking specifically at assessing mental health concerns that are presented to reception. So somebody would call up with a mental health difficulty, and that can range from SMIs, so serious mental illnesses, right through to your mild and moderate work-related stress, relationship difficulties, bereavement. We obviously look at acute distress, we would look at risk assessments, and we look at the kind of acute management of that within primary care. We can offer kind of short-term personalised care. A lot of this focuses around kind of self-management, so looking at self-management strategies, tools, coping strategies. And we also look a lot at referring on to the services that are out there. There are a lot of services out there, but often people don't know where to turn for that, where to look for it. And a lot of the role as well is signposting and linking with those services. We focus a lot on how the mental health is impacting on daily life, so the effects that it has on their day-to-day function. So again, this can include that vocational support like Jen's just talked about. And as we've mentioned, we are now involved in being able to write those Med3s, so we can issue those out. So if we move on to the next slide, Desi, I can talk you through a little bit of a day in a life of what we might experience as a first contact mental health OT. So the clinics do run quite fast paced, quite full clinics, and it's a range of things that you can see in a day, and the people that we see range from all ages. So if you look at this example, we've got, youngest there is 20, and then the eldest we had was 85. And we deal with a range of different things. So some of the examples on here, so we're looking at relationship difficulties, people presenting with anger problems, fear of abandonment. We've got somebody who's got possibly depression, history of poor engagement, You know, a lot of our work can be as well that if we need to do those links with secondary care services, we can, because at times there can be that disengagement from secondary services, and then people, for want of a better word, bounce around the system a little bit. But actually, you know, we do see an important part of our role of linking those two up, that primary and that secondary care element, so that we can have that fluid flow through really for patients. You know, we do assessments with people who have grief difficulties. We also do support people with physical health difficulties that are starting to impact on their mental health. So, you know, people can experience a lot of frustration and anger at the changes that are happening because of those physical health difficulties. And we can do work around that as well. We also obviously offer follow-ups. Now, it's different in each of the areas as to how many follow-ups are offered. So where I particularly work, we can offer up to 6 sessions with people, but this is, like I say, PCN dependent. So some of the examples of things that we will do with people, you can see here, we look at some activity scheduling, we can look at pacing, we can look at sleep issues, we focus on employment support. We will look at medication. So obviously, although we're not prescribers, having worked in mental health for a long time, I've got quite a good understanding of those kind of core mental health medications that are used. So your antidepressants, the anxiolytics. So we are able to discuss that with the GPs, and they will often give prescriptions when we ask for them to, and we will do the reviews of those prescriptions and ensure that people are, you know, settled onto the medications appropriately through liaison with the GP as well. A lot that's coming forward at the moment is autism and ADHD. So we are able to do those onward referrals. We can explore appropriate tools and strategies because wait lists are very long at the moment, and we are aware it is a big gap. So we're able to give kind of some tools and strategies to try and help people to manage whilst waiting for further assessments. So it kind of is a huge range, and each day you wait to see what comes through that door. But it's interesting. It's really interesting to get, you know, the different things that you come across and how best you can help those people. If we move on to the next slide. So as I said, each PCN primary care network is focused on their own kind of criteria, and they will have those discussions as and when, you know, the services are set up in there. So this is an example of one that we use. So you can see here as inclusion criteria, we have low mood, anxiety, work-related stress, you know, your SMIs, so the bipolar, schizophrenia, psychosis. We can help support when people are having, you know, reactions to acute life events, bereavement, job losses. Again, looking at long-term physical health conditions and how that's impacting on mental health. We can explore sleep issues, poor motivation, interest levels, confidence and self-esteem. We try to offer support for people with drugs and alcohol issues as well, because often that can be a barrier for people being able to access mental health services. Often there is a kind of exclusion criteria that they can't be using substances. So we try to offer some support around that and help them to be linking with the substance misuse services whilst trying to give them a little bit of that mental health element support as well. And obviously anybody who's having difficulties meeting their kind of basic needs, their activities of daily living due to a mental illness. So some examples of things that we might exclude from our criteria. So my particular PCN works with 17 years and 6 months and over. Again, that's different in different areas. So there are some areas that will work with 16-year-olds and up. There are some areas that work specifically with children. It just depends on the area that you're in. We don't normally see anything that is just specifically for medication. That will go, you know, we've got pharmacists in the PCNs that can manage that. So we also don't see anybody specifically for physical observation. So sometimes people who are on certain mental health medications need physical health obs doing. That's not something we would do. That would go to another practice member, like one of the healthcare assistants. We don't support at present with any of the requests for sectioning. It's normally the GPs that would engage with that. We also wouldn't normally see people who are already open to a secondary service, because they should be engaging with that secondary service. But as I said before, if there has been breakdowns in communications with secondary services and there isn't a clear picture of exactly what's happening, we can engage to help that pathway. So we wouldn't directly work with the person, but we would look to try and link that back together with the secondary service. We don't tend to do equipment as mental health OTs. We are mainly in the GP surgery, so we wouldn't really be doing home visits. And we tend not to see people who are in mental health crisis, not necessarily because we can't, but because sometimes we do have, you know, it may be a couple of weeks before somebody could be booked in to see us. And if that patient is in crisis and needs to be seen there and then that needs to go to the on-duty GP. Obviously, we do interact and we do try to help with that. So, for example, today I had a cancellation and somebody rang in and I said, yeah, book them straight in with me because I'm free and I can do that. But generally, if I don't have capacity, anything on the day that's a crisis would go to the on-duty GP. So how does it all work? So our appointments, there are no triaging, there's no referral process. The individuals are booked directly into our clinics by either any of the healthcare professionals that work within the surgery or reception. So reception will get a phone call, somebody saying they have got anxiety, low mood, work-related stress. They would be offered an appointment with the mental health OT. We've done a lot of work with the reception staff so that they understand the process of what's appropriate to book into our clinics. We've done kind of quick glance guides and things that they have on reception with them, so they feel confident in making that decision that it could go into a clinic with us. So once they're within clinic and we're seeing them, we'll do an assessment with them. So our assessments are 45 minutes long. And within that assessment time, we would do the assessment with them, and we would also class that as our write-up time as well. It's very fast-paced, and it is what we are looking at is a primary care assessment. So this is one of the things a skill that I had to learn when I first moved into primary care, is getting out of the habit of a full secondary assessment, because we've only ever worked in secondary. In our minds, we're always on that full kind of secondary assessment, but that's not required in primary care. So it's kind of working through what are the need to know, because we have this short period of time to support and help this person, and we're lucky we've got that time. So what are the priority questions that we need to be asking? And that's the skill that you kind of build on and learn as you develop into the role. Obviously, risk assessment, huge priority. Also looking at the red flags. So we are that first contact. Is there something else going on that's causing this problem that is not mental health? You know, if it's older adult and there's confusion, is there UTIs, you know, eating issues and a lot of weight loss? Actually, is that not a mental health problem, but actually there's something else physical going on? So we have to be very aware of that and make sure that that is always at the front of our assessments. We will look at kind of occupational performance and the current impact that that's having on somebody's day-to-day life, the mental health element of it, and explore carers' needs as well. And then following on from that, we'll make a decision of what's the best path forward. So we may do referrals on to third sector or to secondary services if we feel that that is warranted. We will look at a range of different things. So we tend to use quite a motivational interviewing kind of coaching style with our approaches. We look at goal setting and graded activity scheduling. And we try to keep always at the focus is using occupation as a therapeutic tool to help support people. We look at what is the current barriers, what's preventing some of that self-management that often a lot of people do have, but sometimes when things become very overwhelming, that falls away. So, you know, a lot of the work we do is around that self-management. What are the day-to-day things you can be doing that can actually help to support your mental health? We look at the psychoeducation element of symptoms and how that impacts. We are looking at communication strategies, we look at assertiveness, interpersonal skills, we look at confidence and self-esteem, and we do a lot of kind of practical work. So although we're clinic-based, we will do things, we will practice relaxation with people in the session, we will do those self-management techniques so that people feel confident to go from our room and try that and then come back and see how they've got on. If you want to move on to the next slide, Desi. So mental health OT, what is it and what isn't it? So as we said, mental health OT is not an extension of secondary care. It's a completely different role. It's a completely different approach that we are doing here. So it is very fast-paced, and we are looking at that kind of red flag. What is the need right now to support this person and the best route through for them? It's not a dumping ground for the most challenging patients in the GP surgery, although there are elements with that we can absolutely help with. Actually, there are a huge range of things we can do, and the priority is for everybody within the surgery to get support from us as and when they need it. And we're not a last resort. So we're first contact. We shouldn't go through, you know, GP triage with a GP, then through to see a GP face-to-face, who then goes, oh, actually, we've got an OT, let's pop you in with her. It should be that first contact, seeing us when it is needed. So as I said, it is very fast-paced. We have to be mindful that it is time limited because there are a large number of people that we are seeing within the surgeries. And a lot of the focus that we do is on that self-management, that preventative intervention, teaching the tools and the skills and the strategies that people can then go away and feed that into their everyday life. We prioritise providing that psychological intervention, like the NICE guideline recommends, that first line treatment of therapeutic treatment over the pharmacological, because I think historically a lot of it has been mainly because the GPs have limited time and limited expertise, is the first go-to is to try an antidepressant. But actually there's a whole range of stuff we can do before that, and that is what we see as our priority.
So it's over to me now. So thank you very much both for explaining the role so well. So part of obviously the first contact practitioner role, so across all AHPs, is through NHS England, there'll be the FCP Roadmap. So this is to make sure we're upskilling clinicians to the skills required. So both Jenna and Catherine have alluded to, it's not just what you're good at like mental health, or be it about occupation. You do need to identify other aspects of the medical side of things. So is it a patient has come in? Is it that they're actually unwell? So they may have come in for anxiety, but actually they are septic for whatever reason. So it's making sure that we can deal with a lot. So it's not that we have to manage it as the FCPs, but we can identify it and make sure they get the right management as quick as possible. So the FCP Roadmap, there are taught routes through higher education institutions. There's a stage 1 and a stage 2. So stage 1 is very much, there's a taught route through the unis or a portfolio route, which the unis will lead, but that's where you're deeming that you've already got the skills required and you have evidence from previous roles to show, you know, I have an understanding of pharmacology. I am aware of how to identify the unwell patient. I am aware of how to communicate with a wide range of a population. Stage 2 is very much that you have the skills in primary care. So this will include clinical observations, clinical examination procedures, case-based discussions. Every PCN will have almost what they call roadmap supervisors. So that might be another FCP with those skills already. It might be an advanced nurse practitioner, and it might be a GP. And they will watch you in your assessment. So if I go on mental health, so if I'm assessing Catherine, I'm not checking on how she manages her mental health. I'm making sure that how does she communicate? Did she open up the conversation? Is there anything she missed? So is it that the patient's come limping in with a swollen leg and she's disregarded that because it's depression? No, that's where we're making sure that you can look at that wider picture. Part of a requirement is that you have monthly supervision. So especially a lot of the FCP roles, especially OT, haven't really worked in primary care before. So it's making sure that you are supported, even at a more advanced level clinician, but there's always that support to extend those skills. So within Nottinghamshire, we make sure that there are peer reviews. And this is the beauty of OT, is that we have a lot of clinicians that have come from different backgrounds. So use each other to clinicians that have a learning disability, others have an ADHD, ASD background. How can we make sure we learn from each other to help patient care? We run governance meetings to make sure everyone is compliant and that we're keeping clinicians safe. And then we have clinical debriefs. So say our mental health OTs get debriefed by a clinical psychologist just to make sure that they're getting the right supervision. So sometimes the GPs aren't the right person because that's not their higher level skill. And that's where at the Nottinghamshire Training Hub, we can support of how do you get the most and how do you develop your clinicians so that they are working at the best of their potential. And as I said, going on to how can we help at the Nottinghamshire Training Hub. So my role is very much on being able to discuss the roles. How could they help your PCN depending on the need? We can support with job descriptions and with recruitment. We have, and again, this is not exclusive, this is kind of skeleton to help minimize that extra work. So we have kind of an example rota to protect our staff as well. So that's where in GP land, there's a lot of pressures and there is a lot of risk that you end up overloading clinicians. So we try and make kind of a set rota to make sure that clinicians are protected, that there is admin time, they have the time to give those patients that quality assessment. We support with induction plans. What do the clinicians need to know about the GP practice, about the different roles, and also about the wider system of who can they refer to, who could support a long way. So we've got the, say, social prescribers, the health and wellbeing coaches, the other R's roles that are going about that can support the quality care that the FCP OTs are providing. And then we also support with upskilling. So I've already talked about the NHS roadmap. We do examples of like helping with personal development plans. At the Nottingham Training Hub, we provide training as well on a training needs analysis. What do clinicians need more? So for example, it was identified that menopause is a very big thing that shows up in primary care. So we made sure that we're upskilling clinicians of various clinical backgrounds. So not just the GPs, but say OTs will see menopause and how it affects their occupation. It's all from our point of view, and we were very fortunate that we got some questions from Twitter or from X. So I will hand over to Jen. So she has already prepared these. So thank you for submitting them in.
Yeah, great. Really, really great questions. So we got 4 questions around occupational therapy in primary care. The first was around our role as part of social prescribing and working alongside social prescribers, and a particular request to promote, this was a publication that came out by the Royal Society of Public Health, which is a framework for all allied health professionals, explaining when we're actually offering social prescribing ourselves and when we're working alongside social prescribers. So I'd look at the framework, but actually, if you go to our primary care web pages and on the sort of the landing page of that suite of different pages, you'll see that there's a webinar, and it's me interviewing 4 occupational therapists who work in primary care with various different backgrounds. And I think they articulate very, very well. There's a question about how do you work alongside other members of the primary care team? And I think they articulate very well their role and how they're working alongside or as social prescribers, depending on what that particular primary care population needs. So I think that's the answer to that question. Anyone want to say anything else about social prescribing? Are you happy for me to carry on? So the next question was about carers, and I know Catherine and myself have both mentioned this. So I think what the question meant was, when you're delivering occupational therapy interventions in primary care, do you also consider unpaid carers? So this can be friends or family members who are supporting someone with a mental health problem or an older adult. And the obvious answer is yes. What I would say is we've got a great case example on our website. This happens to be from Wales. So it could have been from any part, but it is from Wales. And this is where occupational therapists have been working as that that main key contact, that key person that everyone knows is the key contact in the GP surgery for people living with dementia and their carers. And obviously in those situations, the intervention is not just to the person with dementia, but to the carer as well, and not two separate entities. They're interdependent on each other. So the OT intervention takes all of that assessment and intervention into that. And definitely we find by offering strategies to help with behaviour management that can be associated with dementia, and that focus on meaningful occupation, how do people with dementia stay active, it helps reduce the carer burden. So hopefully, anything else anyone wants to say about our role with carers? I think that's okay. Okay, should we do the next sets of questions then? Last two questions. This question was about giving a bit more information in depth about the vocational role, the vocational offer of occupational therapists in primary care. Actually, there's quite a lot of information out there, in addition to the information I've mentioned and the case studies I've mentioned earlier. If you look at the FCP OT Roadmap that Desi has described, there is a whole section of that. In fact, there's 4 pages that go into quite a lot of detail about the skills, the presentations that we work with, the assessments that we might be using for vocation in primary care. So hopefully that will answer that question for you. And the last question was a great question. I really enjoyed this one, about how are we delivering proportionate universality. So this is about linked to this idea of the social determinants of health. And of course, we have certain groups that have a higher level of health needs. They experience health disparities. And again, just a really good example of occupational therapists offering this type of proportionate universality is working with people with learning disabilities, for example, traditionally had very poor health outcomes. And this has all been about occupational therapists as sport for confidence, working with the GP surgeries around how can we help make GP surgeries accessible for people with learning disabilities. Remember, it's the front door of healthcare. So if you're struggling to actually even access, or you never access the front door of healthcare, it makes any of your needs, very, very difficult to meet. So again, I'd point you to that example. And I think that's it for the questions. They were the 4 questions we got. Really, really great, interesting questions.
Perfect. Thank you very much. And thank you both for your time. I'm going to put you both in the hot seat now with some quick answers. What would you advise? So students currently studying OT, what would be your single bit of advice about going into primary care?
Shall I answer this?
We can go both ways.
Look at the examples. 3 of our action examples have been co-written by students. So it's students talking about what they did on placement in primary care. So if there's one piece of advice I would give, I would go and have a look at those, because they give a really clear idea of what could be some of the things that learners could be doing on placement to learn more about primary care. So that would be my top piece of advice.
We just finished with a student, and I have to say I was a little bit apprehensive, because obviously having not had students in primary care and it being a whole new realm for us all, we were a little bit worried about how it was going to work. Are we going to be able to meet the needs of the students? Will they be able to tick all their learning outcomes? But actually, it was absolutely the best experience I've had with student. It worked really well. There's such a huge scope for them being in primary care. So, I would implore students to reach out and ask for those primary care placements to get that experience, because it's been really positive for us. And I know the students' feedback was really positive as well. And the feedback I've had from other OTs in other areas of primary care that have had students have had very similar experiences.
And this is a question for you, Catherine. What is a bit of advice you would give to an OT entering primary care for the first time?
Oh gosh, enjoy it. It will feel very scary, I think is probably the best word initially when you first start, because it is very fast paced, as we know primary care is. But with the right structure and the right support, you will settle into it. And what you get from it is just really positive. Like, I get such a positive feeling from the end of the day with the work that I've been able to do with people, and the changes that you can see even in just that one session. My absolute thing for people is really embed yourself within the surgeries, make those surgeries your best friends, because they are such a help and support, particularly the admin staff. They know it all. So if you need anything with systems or anything like that, speak with them. And they're your team. So although we're a primary care network role, sometimes people can say they feel quite isolated because you're not directly employed by that surgery. That's the way ours works over here. And I would say that actually you embed yourself within those surgeries and you become part of that team, and then you have that support all around you. So even if you're the only OT there, you still have that help and support on hand.
I'll probably just add on that is that, yes, it can be a fast-paced and isolating role compared to historic days where we had a notes room, we had the collective place that we saw each other. And I think my bit of advice, I guess, I'm not an OT, but as a physio, is use each other. So even though you might be the only OT in the building, but actually call upon your colleagues, because actually they can help a lot. We're in a world now where Microsoft Teams, there's nothing to stop you calling. And I can say with a lot of experience that, say, Catherine and I will call each other a lot in terms of in the day, because sometimes that's how you get that interaction. We are in a different world. We don't have the classic notes room, but that's probably thinking outside the box, which is what we're all very good at.
Our own. Yes.
To make sure you maintain that team environment and embed yourself.
Yeah.
Any final words of wisdom, Jen, from your point of view?
No, I mean, as we're talking about advice, one of the things that came out of the research study was, I think we had all underestimated when we first started working in GP surgeries the degree of education that we needed to bring to the system about the OT role. And that's why doing webinars like this is so invaluable. So the other tip I would give to people, and it's great that, for example, you gave that template for scheduling, because actually, of course, we've got great clinical skills, but we have great skills in helping to educate the system, helping the primary care team understand what the OT role is and other parts of the system. So there's definitely something about how do we educate the system about what the occupational therapy potential and role is. So many people think we just do equipment. Yeah, we do great equipment, but we do about 1 million things in addition to that. And the second thing is about outcomes and metrics. So this is not just occupational therapy specific. This applies to all of those new roles in primary care. What we're realizing is it's actually difficult to collect the data around outcomes and metrics at a national level. So I don't know what the answer to that is, but what I would say is right at the beginning, start to think about how you're going to show impact. So what are the things that you can measure, and get support for how that could happen, because it's a really crucial part of actually showing what we're delivering. So that's all I wanted to say.
Brilliant. Well, thank you very much for your time. So thanks, Jen from Royal College of OT and Catherine Seals from Nottingham West PCN. So as I said, if you want any further information, have a look on the Nottinghamshire Training Hub website. There are lots of different webinars and courses that can help. And then if there's any further questions, then our details have been added. Thank you for your time and good luck in primary care.
Thank you.